Welcome to the 3-Minute Read podcast. I'm John Dalton, editor of the twice-monthly newsletter of the Healing American Healthcare Coalition. Joining me once again is Ed Eichhorn, the coalition's co-founder and co-author of Healing American Healthcare, a plan to provide quality care to all while saving $1 trillion a year.
Hi, John. It's nice to be back again this week.
Well, together, Ed and I have nearly a century of healthcare experience, and we're still trying to figure it out. You can find our background and contact information at the end of the podcast. We launched the 3-Minute Read last March to summarize some of the critical issues that are affecting busy clinicians and physicians as they continue to struggle through this pandemic. Today's issue launches our second year of publishing what we hope you found to be timely information on these issues. For America, February was a month of horror and of hope. Horror when the COVID-19 death toll passed 500,000. Hope with the approval of J&J's safe and effective single-dose vaccine. The horror continues. As we record today's podcast, America's COVID-19 death toll will reach more than 521,000. That's the same as the total number of combat deaths in World War I and World War II combined. But hope is on the horizon. With more than 80 million doses of vaccine having been administered, the first article in our issue outlines a timeline for a return to normal. So let's dig into the latest 3-Minute Read, published March 4th, 1 year after New Jersey's first confirmed COVID-19 case. That was when Metro New York joined Milan and Madrid as epicenters of the global pandemic. So our first article appeared in The Atlantic, written by Joe Pinsker, and it's called The Most Likely Timeline for Life to Return to Normal. And as you can see from the icon, the new normal still includes masking. The author expects an uncertain spring, an amazing summer, a cautious fall and winter, and finally, relief in 2021. For the next few months, daily life will continue to be far from normal. The wild card of the equation, as we're all aware, is the potential emergence of a virulent, vaccine-resistant variant of the SARS-CoV-2 virus. There are a couple of them already raging. In Britain, the B.1.1.7, and Brazil, the P.1 variant. Fortunately, most of the scientific research seems to indicate that the vaccines that are being produced do prevent serious illness and death from those variants. By spring, small gatherings of vaccinated people should be possible. So we can start to tune up the barbecues. Warmer weather, late spring and summer, will make many activities even safer. We can start thinking about taking public transit, being in an office, going back to the workplace, dining inside restaurants, and traveling domestically. But we won't see indoor concerts, we won't see full stadiums, and we won't see international travel. Travel bans will still be in place this summer. Fall, with colder weather, we may see a resurgence of the virus, but the new vaccines should be able to tame them relatively quickly. So, beyond next winter, the experts do expect a return to what we will see as a post-pandemic normal. The next article is the first one we've actually excerpted from the American Journal of Infection Prevention. It's interesting, as you can see from the icon, we've all seen these for the last several years. Protect yourself, get the flu shot, get that seasonal flu shot. It's a study that looked at the impact of the influenza vaccine on COVID-19 infection rates and severity. And it was written by several co-authors. What they looked at was a retrospective cohort of 27,201 patients who had been tested for COVID-19 between February 27th and June 15th, 2020 in the Michigan Medicine healthcare system. And what they found was interesting. People who had received the influenza vaccine, the seasonal flu vaccine, were less likely to test positive for COVID-19. If they did get infected with the virus, they were less likely to need hospitalization, mechanical ventilation, or a longer hospital stay. The research suggests there's a possible association between getting your seasonal flu vaccine and decreased risk of COVID-19, and even if you contracted COVID-19, better clinical outcomes. So This fall, we managed to avoid the dreaded twindemic. Through the spring and summer, there was a lot of concern expressed that with seasonal flu on top of COVID-19, our hospitals and the healthcare system would be overwhelmed this winter. We had some early indications from the Southern Hemisphere, because our summer was their winter, that the seasonal flu in the Southern Hemisphere this past summer was nowhere near what it had been in prior years. So we did kind of expect a mild seasonal flu season. However, mild is an understatement. As of February, early February, there were only 1,363 confirmed cases reported to the CDC. And that compares with an average of 401,000 at the same time during 5 prior flu seasons. I was at a hospital board meeting at the end of January and asked the obvious question, what's happening with the seasonal flu? Are we overwhelmed? And the answer from our chief medical officer was, no, we haven't seen hardly any at all. That's what left us with capacity to deal effectively with the COVID-19 pandemic. We're still in a horse race between vaccinations and variants, but today I think we're in a little bit better place. Ed, any comments?
I think this is important information, and we should keep it in mind, because even though we're all focused on the pandemic, when the flu season rolls around next year, we should all get flu shots once again. So I think this is important just to remind us of where we need to be. I'm going to discuss 2 articles that we featured in our current issue that deal with nursing concerns that have been raised. The first article is by Teresa Brown, and it appeared in the New York Times on February 28th. It's entitled, "American Nursing is Having a Crisis." Teresa Brown is an American clinical nurse and a frequent contributor to the New York Times. She is also the author of 2 books about nursing called The Shift and Critical Care that share accounts of the complicated challenges that nurses deal with every day in normal times. In this article, she interviewed 6 veteran nurses throughout the U.S. with evidence of the growing shortage of nurses as caregivers. The Bureau of Labor Statistics projects that 176,000 new nurses will be needed every year through 2029. Nursing schools don't have enough faculty to expand the nursing workforce as is needed to meet these future demands. Beyond burnout, research suggests that COVID ICU nurses are now suffering from moral injury, which is also known as PTSD, a term more typically applied to combat soldiers. Brown quoted an El Paso ICU nurse that said, "It's a moral injury when I leave a hospital bursting at the seams and all the bars and stores are full of people." To take just a brief digression here, leadership and public health intersect when we have to work our way through a crisis like the pandemic we all face every day. It's not easy. Our elected officials need to make decisions in times like these that affect the economy, the business community, and consider public health issues. This ICU nurse lives in Texas, and this Tuesday, her governor, Governor Abbott, announced that he is ending the statewide mask requirement and is allowing businesses to fully open. It's certainly true that everyone in America would like to return to life as normally as life was before the pandemic. Times of great crisis demand the best of our elected leaders. The pandemic really demands that they think carefully about the decisions they make, and they should try to be careful about following the science. Not following the science doesn't make it go away. In this decision, the governor is ignoring science and the data that his state will use to make the jobs of ICU nurses in Texas even more challenging. Today, the infection rate in Texas is more than 7,000 patients per day, and it's higher than it was last summer during the second peak in his state. The death rate has climbed from 8.3 per 100,000 at the end of last June to more than 150,000 at the end of February. That's an increase of more than 1,700%. The vaccination rate as a percentage, when compared with other states, is 48th. It's only higher than Utah and Georgia. The injection rate for Texas is only 13%. Texas is not anywhere near herd immunity. His decision will likely cause an increase in cases over the next 3 to 4 weeks that will add to the burden of nurses who work in Texas. To return to the article, there are some additional quotes that Teresa Brown included that are worth repeating. Another ICU veteran is studying to become a nurse practitioner. She said, I am going into primary care to keep people out of the hospital. We never had enough nurses. A second nurse, a veteran from Pittsburgh, said, going into the pandemic, we were not prepared. We never had enough nurses and support staff. We never increased the nurses. In 2020, an HFMA report shows that having enough nurses in hospitals can actually save money. However, 36 of America's 60 largest hospital chains have laid off, furloughed, or cut the pay of staff members to save money during the pandemic. Teresa Brown calls for changes in the profession that include creative ways to bring more nurses into the workforce, adding faculty at nursing schools, and making them more affordable. The next article that appeared in 3 Minute Read this week is about nursing homes. The title is Average Nursing Home Nursing Staff Turnover Exceeds 100%. This article appeared in Modern Healthcare and was written by Ginger Christ. She was commenting on a health affairs article that was released this week that reported that the average rate of nursing home staff turnover exceeds 100% per year. The turnover for registered nurses in this market segment was 140.7%. The rate for licensed practical nurses and certified nursing assistants was 114.1%. This was a very comprehensive study because it covered more than 15,000 nursing homes with a combined census of more than 1 million patients. The study found that nursing homes with higher levels of Medicaid recipients had higher turnover, largely because the pay to work in these facilities was lower. A study co-author, Dr. Ashin Gandhi, who is an associate professor at UCLA's Anderson School of Management, said that we see fairly clear evidence that higher turnover rates tend to be associated with lots of factors that are associated with worse quality of care. The authors recommended nursing staff turnover rates should be included on the CMS Nursing Home Compare Quality Rating System so that prospective patients and potential employees can better evaluate facilities.
Interesting. That's an article from the March 1st issue of Modern Healthcare. The prior issue of Modern Healthcare also looked at staffing stress and its effect on nurses. They quoted some of the studies being done by the American Nurses Association, which is the professional organization for nurses. They point to one of our local hospitals, St. Peter's University Hospital in New Brunswick, as an example of maintaining adequate staffing levels without having mandated ratios as does California, for example, the nurse-to-patient ratio. St. Peter's is a 478-bed teaching hospital and part of a project from not-for-profit organization of nurse leaders of New Jersey. That organization is focused on establishing councils at hospitals throughout the state. The councils include frontline nurses and leaders who work together to address staffing concerns at their facility. So St. Peter's maintained that council even during its surge of COVID patients in the spring when we were part of the global epicenter of the pandemic. And their chief nursing officer indicates that some nurses did take leaves of absence due to childcare responsibilities because of course our schools shut down. But no nurses left St. Peter's due to poor or unsafe working conditions, and staffing ratios haven't been impacted. They maintained strong staffing throughout COVID-19 because they regularly engaged with staff and implemented suggested solutions. And to quote Linda Carroll, who's the chief nursing officer, our staff is our biggest voice. They know what is needed at the bedside. So there is a glimmer of hope in the whole issue of staffing and burnout, so long as you have participative management that empowers nursing staff to speak up. with that, let's turn to my blog. This is my first blog, and it came about last Sunday as I was watching some of the snippets from the CPAC meeting where we kept hearing about America first. Because on health, America is really worst. For those of you who read my 2016 series of articles that appeared in my professional organization magazine, they were entitled American Healthcare and posed the question, worst value in the developed world. Using data from folks like the Commonwealth Fund, the World Health Organization, the OECD, I demonstrated that when it comes to healthcare, America is not getting the bang for the buck. We are the worst value in the developed world. Surprisingly, at that time, when we looked at all of the data and all of the research, Britain's National Health Service was first in the world in terms of being able to deliver quality healthcare at affordable costs. So last week, there were two sets of data released, one from the Commonwealth Fund. And by the way, for anyone that's monitoring health policy in the US, the Commonwealth Fund and the Kaiser Family Foundation are both very credible sources of current data. Worldwide, it's more the World Health Organization and the Organization for Economic Cooperation and Development that monitor this data. So today we'll be talking about data from the Commonwealth Fund and a report that was released by Lancet, which is the British equivalent of the New England Journal of Medicine. But let's go back to the Commonwealth Fund. They have for years have monitored the 11 high-income industrialized nations who are part of the 37-member OECD, Organization for Economic Cooperation and Development. Each year, they update performance for Australia, Canada, France, Germany, Netherlands, New Zealand, Norway, Sweden, Switzerland, the UK, and the United States. So those of you who have been following 3-Minute Read know that we've covered health issues in several of those countries over the past year. America is the only member of the Organization for Economic Cooperation and Development that does not recognize access to healthcare as a fundamental human right. And we do not provide universal healthcare for all. The only member of the OECD that does not. So let's examine the data. The data have multinational comparisons of health systems data 2020, and it was put together by Rusa Tikkanen and Catherine Fields of the Commonwealth Fund. The first chart that the Commonwealth Fund presented is healthcare spending as a percentage of gross domestic product from 1980 through 2019. So here at the left-hand side of the chart, back in 1980, healthcare spending as a percentage of GDP ranged from about 5% to 8% of GDP, with the US at the top along with Germany and Norway. Over time, you can see that we have managed to outpace the rest of these countries by a wide margin, winding up in 2019 at 17% of gross domestic product. At the other extreme, we have Australia and New Zealand spending a little more than half of what we spend as a percentage of the gross domestic product. Germany at 11.7%, Switzerland at 12.1% are the two that follow us most closely. The next chart looks at per capita spending by source of funding. And you can see that New Zealand is the lowest at $4,205 per capita spending on healthcare. The average for the entire 37-member OECD is $4,224 right here. And then for the US, again, is at the high end at $10,637. So that means for a typical family of 4 in the US, you're spending about $42,000 a year on healthcare. Part of it's out of pocket, $1,150 per capita. Part of it's private spending, part of it's public spending. Switzerland is the highest on the out-of-pocket costs. The typical Swiss spends $2,000 out of pocket annually. Switzerland was one of the last of the OECD countries to move to universal health care. And as we followed their cost trends, they tend to be the second highest after the US. The next chart is life expectancy at birth. In 1980, we have the US at about 73.5 years, the UK and Germany at about 74 years. And then over time, we see where we've gotten to in terms of life expectancy. But currently, the UK is at 81.3 years and Germany at 81 years. The best in the world are the Swiss at 83.8 years, although I think Japan is also up in that range. So we have Switzerland 82.8, Norway at 82.8. I think Switzerland being a mountainous country, that may have something to do with the health of their citizens because they have to climb mountains every day. But the US has not been able to keep pace with the other countries in terms of increasing life expectancy. And this data is only through 2017. We do know that for the first 6 months of the pandemic, the US lost a full year off life expectancy, and for Blacks and Hispanics, it was closer to 3 years. So what's the difference? The UK, we were pretty much on par with them through 1990. From 1979 through 1997, Margaret Thatcher and then John Major were in power as prime ministers, and the Conservative Party was in power. During that period of time, the investment in the National Health Service was pretty much flatlined. Tony Blair took office in 1997, and then he and Gordon Brown from the Labour Party were in power as prime minister through 2010. 1997 through 2010, the UK's life expectancy continued to parallel the rest of the OECD. From 2010 onward, they started to falter a little bit. Basically, once David Cameron and Theresa May took office as prime minister, there was a disinvestment in the National Health Service. So much of the data that we looked at during this time period, from about 2006 through 2015, the National Health Service was delivering top quality care at an affordable cost. The quality has slipped, and the UK has had significant difficulty coping with the pandemic. So disinvestment in the National Health Service has come at a cost of British lives. If you look at suicide rates, again, the US is worst among the 11 nations. The average suicide rate for the OECD is 11.2 per 100,000. For some reason, the UK is at the low end, followed by Germany. Look at adults with multiple chronic conditions. What do they count as chronic conditions? That's adults age 18 years or older who have 2 or more of the following chronic conditions: joint pain or arthritis, asthma or chronic lung disease, diabetes, heart disease, including heart attack, hypertension, or high blood pressure. The US, 29% of adults over 18 in the US have multiple chronic conditions. France, Netherlands, Switzerland, below the 11 country average of 17.7%. So the US, again, is worst among the 11 countries. Obesity rate, US highest in the OECD at 40% obese. That's a body mass index greater than 30. At the low end, Switzerland, Swiss and Norway are both mountainous countries. That may help account for their low obesity rate. Within the US, Colorado has the lowest obesity rate at 23.9%. Again, a mountainous state, so that may have something to do with the rate. New Jersey is at the lower end with 26.9% obese. Mississippi is at the highest at 41%. And unfortunately, we do know that the World Health Organization has found that 88% of COVID-19 deaths are in countries where more than half the population are overweight, and that includes the US. After age, obesity is the second highest risk factor with COVID. So not good news for US health. The one area where the US is at the top of the chart is in breast cancer survival rates. And unfortunately, these data are only from 2010 through 2014. We don't have data subsequent to that. So the OECD average for 5-year survival rates was 85%. The US is at 90%, and that's been a major focus of research here in the US, thank God. However, the second part of the chart, cervical cancer, the US is at the bottom of the barrel again with the lowest 5-year survival rate. So the Commonwealth Fund data is not good news for health in the US. Moving on to the Lancet, and that's the British journal, let's see, pretty much considered the equivalent to our New England Journal of Medicine. So in early February rather, they released the report of their Lancet Commission on Public Policy and Health in the Trump era. And it's not good news for the US. Why did they form it? They felt that the Trump administration policies posed a uniquely urgent threat to health. So the commission was established in 2017 with 33 commissioners with a wide variety of educational and professional backgrounds, equally from Canada, the UK, and the US. The aim of the commission included identifying major health-related policy actions in the Trump era, that's 2017 through 2020, evaluating emerging data on their effects, and then finally recommending alternative and more salutary policies to the next US administration. I went through the entire report. It's very lengthy, it's thorough, it's well-researched, and it's wide-ranging. It's highly critical of the Trump administration on many fronts, including the environment, white supremacy and racism, immigration, the opioid epidemic, and food, nutrition, and public health. I'll limit my remarks to public health. So let's see what they found. They're very critical of actions taken by the Trump administration prior to the pandemic, including when Trump took office, they imposed a hiring freeze on the CDC. It left 700 positions vacant, mostly scientists and physicians. They also halted OSHA's. OSHA is the Occupational Safety and Hazard Administration part of the Department of Labor, that cabinet department. OSHA was finalizing regulations on airborne infection control standards for workplaces. They halted all development, the finalization of those regulations. And I think we all remember back last spring when there were massive outbreaks in many of the meatpacking plants. And I think most of the major networks spent a full week in Sioux Falls, South Dakota, reporting on the outbreaks of COVID-19 in those meatpacking plants. In fact, at some point, we saw meat prices going up because there was a shortage. They also eliminated the National Security Council's Global Health and Biodefense Directorate in 2018. It's a fancy title, but the core component of that directorate was the group that wrote the pandemic playbook coming out of the Ebola epidemic. Remember when Obama took office in 2009, we were hit with the H1N1 flu, and then a few years later in 2014, the Ebola epidemic emerged in Africa. Obama insisted that we've come out of that Ebola epidemic that was confined to Africa because of massive intervention early on. We did a lot of the right things. So out of that, we created a pandemic playbook, which a lot of the rest of the world used during the COVID crisis, but we eliminated the department that did that. So we were left weaponless. So what does the report state? Quote, Trump's mismanagement of the COVID-19 pandemic, compounded by his efforts to dismantle the USA's already weakened public health infrastructure and the Affordable Care Act's coverage expansions, has caused tens of thousands of unnecessary deaths. Now, we routinely monitor the OECD and the fatality rates throughout the OECD. As of February 28, 2021, we looked at excess deaths in the US versus the OECD's average. So if we had just performed at the average for the Organization of Economic Cooperation and Development in 37 countries, 150,000 more Americans would be alive today. If we looked at Germany, Canada, or the 4 Nordic countries, those numbers would be much, much higher. So I've got to believe that somewhere in this country, there's a group of defense attorneys looking to put together a class action lawsuit against Trump and the Trump administration for wrongful death. I mean, all the evidence they have is in the Woodward interviews. All the evidence they need is in the Woodward interviews. So where do we go from here? The Lancet Commission report came to the following conclusion with respect to health. Quote, the suffering and dislocation inflicted by COVID-19 has exposed the frailty of the US social and medical order and the interconnectedness of society. Remember, the first case diagnosed in the US was in Washington State and was a traveler who had returned from Wuhan, China. On the other hand, what hit us in Metro New York were travelers returning from Europe with the virus that they picked up in places like Milan and Madrid. The report continues, a new politics is needed, whose appeal rests on a vision of shared prosperity and a kind society. Healthcare workers have much to contribute in formulating and advancing that vision, and our patients, communities, and planet have much to gain from it. So one such vision is described in detail in the book that Ed co-authored, Healing American Healthcare, a plan to provide quality care for all while saving $1 trillion a year. The Eichhorn-Hutchinson All Care Plan depicted therein provides a practical path to universal health care for all Americans. Like Biden Care, it builds on the strengths of the Affordable Care Act without imposing the economic disruptions that would take us to a Medicare for all kind of coverage, a single payer system governmentally run, similar to the National Health Service. So where are we? In my judgment, it's time for all Americans to unite behind moving America's healthcare system from worst to first. And frankly, there is some hope on the horizon. It's happening. It's beginning to happen. When I wrote this blog last Sunday, there are a couple of things that have happened since then that are good news for all of us. Merck has agreed to manufacture J&J's vaccine. And with that happening, there will be sufficient supply so that all Americans can be vaccinated by the end of May. That's adding to the 80+ million doses already administered. And 64 million of those have happened in the 6 weeks since President Biden was inaugurated. The current vaccination rate now is running higher than 2 million a day. 2 weeks into open enrollment, more than 200,000 Americans have signed up for private healthcare insurance at healthcare.gov, and more signing up every day. So we're expanding coverage. And it appears that the American Rescue Plan, the COVID-19 Rescue Plan, will finally pass the stubborn Senate sometime next week. So hope is on the way. Ed, any concluding comments?
Yeah, thanks, John, for that insightful analysis. You know, in addition to the 2 million a day that you referenced that we are at now, there's still another vaccine in the United States that should be approved probably sometime in April, and that's the one from a company called Novavax. And they are taking the risk of producing the vaccine now, and they expect to have 106 million doses available by the beginning of June also. And I think that would help the United States in its place in the world, because if we will have enough doses for Americans, that means we will be ready to provide doses to other countries that need to have vaccines in order to control infection in their countries. And in the poorer nations of the world, less than 2% of their citizens in 72 of the poorest countries have actually been vaccinated thus far. So I think in addition to the great news that we can provide inoculations to everyone in America who wants one, our country will be in a position to provide support for the increased need for vaccinations around the world. I also wanted to thank you for talking about the Eichhorn-Hutchinson All Care Plan in your analysis of how we might move forward. And in response to that, we're going to do our next podcast on our plan and compare it to Medicare for All and the current congressional effort to improve Obamacare that will follow up the bill that you mentioned for the $1.9 trillion bill to help end the coronavirus pandemic's economic issues in our country. So hopefully the podcast that we can do next week will provide a clear and concise comparison to these approaches to universal health care so that our listeners can decide what plan might work best for them that they could support. Once again, I want to thank you for listening to our podcast today. Please take our brief survey at our website, www.healingamericanhealthcare.org. We look forward to providing our next podcast on universal health care in the United States over the next week. Thanks, and be well.
Thank you. We'll see you next time.